Welcome to AETCM, the emergency medicine channel. Now let us discuss about ventricular ectopics and VT. So once you know what is ventricular ectopic, you will understand what is VT. So ventricular ectopic means this is your atrium, this is your ventricle. Normally SA node to AV node conduction will happen and it will go to the conduction system. You get P, QRS, T wave. Okay, but due to some reason, if the atrium is not producing any electricity, it may start from the ventricle and it will go to the conduction system and then again come back to the main conduction system and activate the ventricle. So it takes a longer time. So you get a wider QRS complex. There is no atrial activation, so you don't get any P wave. That is ventricular ectopic. So this is P QRS complex T, but ventricular ectopic means there is no P wave. QRS complex is wider because it takes longer time and it is near to the first complex. That means normal first complex, and delay, there is a delay after the ventricular conduction, then next complex comes. So this is ventricular ectopic. This is also called as ventricular premature complex. Now VPC types: unifocal, multifocal and multifocal which is repeatedly coming. Okay, unifocal means this is again your atrium, ventricle. Atrium is not producing any electricity, so every fourth or fifth there is an electrical activation from the ventricle because atrium is not working here. That produces one ectopic. After many beats, again one more ectopic. So if both are similar, you call it as unifocal, that is only from one focus. Suppose ventricle is not good, or is there if there is an electrolyte imbalance or problem in the ventricle like ischemic heart disease, it can also generate from other focuses. Okay, then the morphology of the VPC may be different. Okay, they are called as multifocal ventricular ectopic. So multifocal means different morphological ectopics. They are always dangerous because multiple area ventricle is not proper and it produces multiple different types of signals. So multifocal ventricular ectopic. So unifocal is always better than multifocal, but if the number of unifocal ectopic is increasing, then that is also dangerous. Now VPC and APC, ventricular premature complex and atrial premature complex. You look at this one. So here wide QRS complex within this one, wide QRS complex with ST depression T wave. These are VPCs. There is no P wave. There is no P wave. Whereas here you can get a P wave which is abnormal from other P waves, which is abnormal, and it has come closer to the first complex. So it is like this PQRS. Next is different P wave from the previous P wave. Then you get a QRS complex. Then the next PQRS comes. Okay. So this is atrial premature complex, whereas the other one is ventricular premature complex. Now we have already seen that if the complexes are coming in a row, we have different names. If the ventricular premature complex are alternate, here there is a multifocal ventricular premature complex, this morphology is different from this, that is different from this, but they are coming alternatively. This is called as bigeminy. Bigeminis are always dangerous, bigeminy. So here also you can see monomorphic but coming alternatively. This is also called as bigeminy, alternative. Okay. Here monomorphic but they are coming alternatively. They are called as trigeminy because it comes after every second beat. First, second, third is a ectopic. 1, 2, 3 is an ectopic. Whereas here alternative beats are ectopics. That's why it is called as bigeminy. Here every third one is coming as an ectopic. That's why it is called as trigeminy. Quadrigeminy means every fourth beat is a third one over 1, 2, 3, fourth is an ectopic. So that is quadrigeminy. Okay. Now what is couplet? Couplet is a different form of ectopic. So QRS complex, normal QRS complex. Next one is you are getting an ectopic. Next also an ectopic, and again you get a normal QRS. So two ectopics in a row is called as couplets. Okay. So couplets also not very good. They can anytime for like forward or go ahead and produce some sort of ventricular arrhythmia. This phenomenon is called as R on T phenomenon. You can see here first QRS complex R, P, Q, R, S, T, R on T. Next R comes on this T, R on the T wave. R on T phenomenon followed by an ectopic is very dangerous. This patient can develop ventricular arrhythmias. So R on T phenomenon also a dangerous type of ectopic that you should remember. R on T phenomenon. R wave of ectopic on T wave of the previous QRS complex. Now there is a grading for ectopic, long grading, grade 0, no ventricular premature complexes, occasional PVCs less than 30 per hour, grade 2 frequent VPCs more than 30 per hour, bigeminy also can be there, grade 3 multifocal ectopic, grade 4 repetitive or couplets, salvos, that is triplets, all these things. Grade 5 is R on T phenomenon. So here what you are seeing is two ectopics in a row, that is called as couplets. This is single ectopic, couplets, single ectopic, quadrigeminy. So different morphological ectopics. Suppose you see a patient in your OPD who is having infrequent ectopics, a very rare number of ectopics you are seeing in a this one grade 1 ectopic. What you do is ask the patient to walk for 10 minutes or 10 or 15 minutes, repeat the ECG. Repeat the ECG. If it is a pathologically significant ectopic, the number will increase. Number will increase. If it is a normal physiological ectopic, number will decrease. If the patient is having significant symptom because of ectopic or the numbers are increasing, then we need to admit the patient and evaluate. Otherwise, these all things are due to various electrolyte imbalances or like our normal physiological changes. All these things can contribute. Now here what you are seeing, there are two ectopics in a row. This is called as couplets. Couplets. Now there are three ectopics in a row here. They are called as triplets or salvo. Couplets, triplets. Here also you can see three ectopics in a row. They are called as salvo or triplets. Now more than three ectopics in a row should be considered as VTs. So here you are getting three ectopics. Actually one ectopic we are not seeing here, and but here it is more than three, that is four ectopics are there. Five. Okay, so they are called as VT. Anything more than 3 is called as VT. So VT can be monomorphic or polymorphic. Here we are seeing monomorphic VT. That means only one format of continuous ectopic, ventricular ectopic, that is known as ventricular tachycardia. Okay, ventricular tachycardia, that is monomorphic. So VT is always VTs are always like it can be dangerous, and here what you are seeing is monomorphic. Here you are seeing a polymorphic VT. VT most of the time they are monomorphic. So any DD you change, see that the change will be same. But here some of the complex are like this, some are like this, some may be like this. They are called as polymorphic VT. So VT can be monomorphic or polymorphic. You have to check the patient stable or unstable. So here there is another type of VT that is called as Torsades D point. This, for simple understanding, I will tell you, draw a baseline. So this, suppose this is PQRS. Okay, so VT means either like this. Monomorphic VT is always like this. either positive or it can be negative. So VT can be either positive or negative, they are monomorphic. Okay, but Torsades D point is slightly different type of VT. This is the baseline. So it will be like this. Some complex will be positive, then some complexes go this side and negative, then again it will go positive. This is called as twisting around the ECG axis. Twisting around the axis. So here you can see some are negative, some complexes are negative. So if you compare, this are the baseline, some are negative, some are more negative, then some are positive going this side, again on the same side. So they twist around the axis. Now R on T I have already explained. R on T phenomenon, R wave of your ventricular premature complex falling on the T wave. So here you can see R on T is a T wave. R wave falls on the T wave. So R on T phenomenon can lead to polymorphic ventricular tachycardia. So that's a dangerous phenomenon. R on T is a dangerous phenomenon that comes in the last grade of the Lorentz grading. Now ventricular fibrillation is slightly different from VT. VT is a more organized rhythm, but if you don't treat ventricular VT, then what happens is it will become ventricular fibrillation and flat line. Okay. Whereas the Torsades point is like this only, but it just twists the axis. Okay, but still it is an organized rhythm. Organized rhythm means there is no P wave, but it's a ventricular complex. Whereas ventricular fibrillation is very fast beating of the ventricle, which is originated from the ventricle itself. That's why it is wide, but it is not an organized rhythm. Now the treatment of both VT and SVT I have given here. VT and VF I have given here. I am not going to explain that in detail here because we are only learning ECG here, but you can save these slides, and remember amiodarone will be one good drug in all these arrhythmias what all we learned in the past classes. But if the patient is having any unstable nature, then you have to either go for electrical shock, cardioversion, or defibrillation depending on the scenario. You have to check the ACLS rhythm management here. Now Brugada algorithm for VT with SVT and aberrancy. So there is an algorithm called as Brugada algorithm. So why I am telling this is, last time we learned wide complex ECG. So it can be VT that we learned just now, or an SVT. SVT is always narrow complex rhythm, but if it is associated with RBBB, LBBB, or WPW syndrome, that also will become wide. Okay, it is highly difficult to identify these two different types of rhythm abnormalities in ECG. That's why ACLS always tell you look for wide complex rhythm. The treatment is this, amiodarone or shock. Okay, that you have to check the ACLS protocol for that. But I am telling there is a algorithm which can differentiate. If you are good in ECG, you can differentiate these rhythms between SVT with aberrancy or VT. And that most important thing is concordance and discordance. There are points given for that. I'll tell what is concordance or discordance, then you will understand. Concordance means if you are taking V1 to V6, we know that V1 is predominantly negative, then V2 it will become positive. Okay, V6 it will be maximum positive. So this is called as R wave progression. So even if in SVT with aberrancy, you can see this type of progression from V1 to V6, whereas VT in all the leads it will be either positive or negative. Okay, so that will be little difficult for a beginner. So that's why ACLS always tell wide complex tachycardia. You treat that wide complex tachycardia, whether it is SVT with aberrancy or VT, the treatment is all same. But if you are good in ECG, you can differentiate. If you are able to differentiate these two things, then you can even treat it like SVT. That is not an issue. Now here what is the problem is positive concordance. V1 to V6 everything is positive. All the complexes are positive. Only size is varying, it never crosses to the lower part. Predominantly it is positive. Whereas negative concordance, everything is negative. All the complexes it is negative. Predominantly negative, it is not completely negative, predominantly negative. Whereas in SVT with aberrancy, that is different. Here it is more positive, here it is more negative. That is following a pattern. Okay. So this is called as concordance. Positive concordance, negative concordance. This is discordant. Some leads are positive, some leads are negative. That goes in favor of SVT with aberrancy. So Brugada criteria I already told. You can check all these things in detail and learn it. We are not explaining that because it's a higher topic that require one full class. So we have discussed about like VPCs, ventricular premature complex, how that progresses to VT. Thank you.